questions, then I can go ahead and read those off to you. So just to avoid having too many interruptions, let's just put the questions in the chat field. Also, just wanted to let everybody know, I'm sure you've seen all the emails, but we are working on a new website platform. Lacey's been working really hard on that. I definitely can't say that I've been spearheading that. Lacey's been mostly in charge, so we appreciate Lacey taking the reins on that. But that should be up and running in a couple of weeks at the most, hopefully in the next couple of days. We just have one last big step to go through before they can officially make the transition. And then I also just wanted to let everybody know that we had voted as a board to have the in-person convention in February of next year. So that'll be Friday, February 11th, 2022. So that's very exciting that we'll all be able to get together as a group and see each other face to face again. So I'm going to pass it over to Lacey and let her introduce our first speaker. So Lacey.
Hello, everybody. I'm going to go ahead and introduce Michael. Michael Faulkner is a clinical education specialist for Signia, and he is responsible for training customers and sales staff on the company's current software and products. Prior to joining Signia, he worked in an ENT setting affiliated with UNC REX Healthcare in Cary, North Carolina. He practiced as a clinical audiologist for 8 years, beginning in 2011. Michael received both his Bachelor of Science degree in Communication Disorders and his AUD from Central Michigan University. Go ahead and take it away, Michael. Thank you again for presenting.
All right, thank you so much. And can you see my screen again okay?
Yes.
All right, perfect. So I'm going to take just a few minutes to talk about some recent updates from Signia before I pass it over tonight. Keeping in mind that this is just kind of a very brief introduction, and that I will be back to talk more in depth about things as they stand, I think May 13th, at the same time as this is scheduled for Signia to do a more in-depth presentation. So this is just a very cursory kind of overview of some of the things that Signia has done in the past year since the last GAA. So with that in mind, Signia has certainly always been an audiology first company. Whenever they bring something to market, introduce a new feature, the number one goal is always how does it benefit the wearer audiologically, while at the same time consistently bringing new iconic innovations to market as well. So in addition to the technology within our hearing aids, we also pride ourselves on designing products that are consumer centric and designs that patients are asking for, hearing aids that they gravitate towards and want to wear because of the way they look. So knowing that anybody who comes into your clinics, your offices, has different needs, we have many different form factors and options for everyone. So with that, our most recent innovation that just launched less than a month ago at this point is the new Active Pro Active hearing aid. Doesn't look like a traditional hearing aid that we've seen before. Obviously, this is a very unique offering from Signia, really designed to completely change the perception of what hearing aids can look like. So it does, look like an earbud that you would listen to, that you might purchase from Best Buy, but it is very much a hearing aid. This is fully on our Experience platform, Bluetooth compatible and fully rechargeable. With this kind of what we call hearable design, it's perfect for those users who feel like there's a mismatch between their personal style and what they feel like a hearing aid should look like. So these devices, for those of you who are familiar with Signia products, they are compatible with our full range of click sleeves, which are also used by our Silk product, and then also our traditional RIC products as well. So that, again, the new Active Pro and Active devices just came out less than a month ago. Like our Stiletto, the charging case itself does carry an additional 3 days worth of charges in it. So with that Bluetooth connectivity and again, that portable chargeability on the go, this is just another example of the type of innovation that Signia is known for. Another product that was just recently launched just prior to Active actually is our new Motion BTE platform on the Experience platform. So once RICs were released, BTEs kind of took a back seat, but as we all know, there's certainly still a market for it. And here we have our most current BTE platform. So you can see we have 3 new models here, starting with the standard motion charge and go at the bottom, to our power, and also now a superpower on our most recent experience platform. And the one thing I would point out is that these devices are all rechargeable, including that superpower. And the one thing that's actually really exciting to point out is that with our superpower, not only does it have T-coil and Bluetooth connectivity, but on a single charge, the wearer can be expected to get up to 61 hours of wear time, which is really unheard of for that power form factor. So with the addition of the motion on our experience platform, we've now introduced the first rechargeable superpower hearing aid. And again, these are all rechargeable. You'll see there are standard cases for each of them, which are the open top cases for the motion charge and go superpower and power. And then for those who are, again, maybe familiar with our products, we have the clamshell charger, which is exactly the same charger that comes with our traditional RIC, our pure charge and go for that standard motion. So, and then what you're also seeing there is our upgradable dry and clean charger. So at that point now you've got charging, dehumidification, and then also UV sanitation as well. Almost exactly a year ago now, we introduced Signia Assistant. So of course, many of you may be familiar by now with our Signia app, volume control changes, sound balance, streaming, but it's much more than that now with the addition of Signia Assistant. So with our Signia Assistant, we now have a personal digital assistant. This is our live neural network. It allows the wearer to make some basic tuning adjustments based on the environment that they find themselves in. And again, this is a live neural network, so it's continuously learning from the input that it receives from wearers across the world. It's a live neural network that exists within the Signia app, does not require any additional programming on your part. So as long as they have a Bluetooth experience hearing aid, this is a feature that is available embedded within the app. And when used, it analyzes the environment and then compares it to thousands of similar events and is able to provide a solution with the highest success rate for that situation. So if the patient is struggling to hear others' voices or sound quality, because of a closed set of options, they can make their selection using the Signia Assistant, and it will make adjustments to their hearing aids in real time in the environment they're having difficulty in. Because how many times has a patient come back to your clinic, and they have a very specific complaint in a very specific type of environment, and more often than not, you're having to make adjustments in a quiet office setting and hoping that translates to the environment that they're having difficulty in. So one of the benefits of Signia Assistant is that it does take that environment into consideration when making those adjustments. So I kind of touched on benefits already, but one of the other benefits of Signia Assistant is that it makes them feel more confident and in control of their hearing aids. They get more input into what their settings are. But just keep in mind that any changes made using Signia Assistant can be undone by the patient, and you as the provider have the ultimate final say. When you detect the hearing aids after any adjustments have been made, you immediately have the ability to either discard those changes or you can implement them. But it just gives you another level of insight into the wearer's individual preferences. And again, because it doesn't require any additional programming, you're not adding a program, it is there. If it's a Bluetooth experience hearing aid, it's going to optimize your time because you don't have to bring them back to add that feature. In a study that we did, we found that 93% of wearers who tried Signia Assistant said that it did boost their confidence, and again, let them feel more in control of the success of their hearing. Additionally, we've also, once the pandemic hit, Signia was actually the first to introduce a dedicated solution for the addition of face masks and social distancing. So with that, we introduced face mask mode to address those very specific scenarios, because now, you've got, of course, any variety of face masks that people are wearing. And, even with the vaccines rolling out, I don't think we're going to see face masks go away too soon. And then also the effect of increased distance from typical conversational distance of 3 feet to now a minimum of 6 feet. So we're actually now into face mask mode 2.0, meaning that as we learn more about the effects of face masks on speech, we're able to incorporate that data into the feature and update it as we go. So there have already been changes, just going to the fact that we are constantly updating and improving these features. Face mask mode is another feature that does not require any programming on the part of you as the provider. It is another feature that's available in the app for Bluetooth experience devices. It is a temporary setting, so meaning it'll be disabled when the patient turns it off. So you can see in this image here, the face mask mode there is currently red. Pretty intuitive icon. Hopefully most people will know what that indicates, but red means that it's activated, gray means that it's deactivated. So unless they specifically disable it, if they change programs or they reboot their hearing aids, those will all deactivate face mask mode. And it's really doing 3 main things. It's increasing high frequency gain, increasing noise reduction, and then moving what we call our dynamic soundscape processing slider 1 step to a setting referred to as highlight, which essentially is going to give more of a frontal focus when it's activated. So again, I kind of pointed out already how temporary it is and when it shuts off. I'm just emphasizing again that it does not require any additional programming. So the benefits of face mask, I feel like are pretty logical, but of course it's going to help the patient understand speech through face masks, which is the goal, just with a simple activation of the face mask icon. As the hearing care provider, it allows you to offer this one-of-a-kind feature to your patients, and it will help you stand out in what you're able to offer them as well. And again, this is another feature that's going to help you save time because it doesn't require any additional programming. If anybody on the call, if you have a set of demos and haven't had a chance to listen to this yet, I would highly encourage you just to program in a mild hearing loss. And with the Signia app on your phone, just do a listening demo yourself. I mean, this has been a big game changer for those patients who are struggling, and with face masks, we've got people who maybe didn't realize as strongly as they should have that they have difficulty hearing, but now with face masks they do. And of course, those who do already have hearing loss who are wearing hearing aids find that they are struggling even more so. And then finally, I just want to summarize by, again, just emphasizing Signia's history of world-class audiology first features and technology. We've had many world's firsts, including face mask mode, our own voice processing, which has been shown to increase first fit acceptance by processing the wearer's own voice independently from everything else in their environment. And our research has shown that it's improved first fit acceptance by up to 80%. In addition to a multitude of one-of-a-kind innovations that are designed to not only combat stigma, but also improve wearing acceptance and ultimately enable patients to live their best life. And our innovations, continue to support those patients. Like I said, face mask mode continues to evolve as we get more information. I didn't address it here, but we do have our telecare features too for remote care, in addition to Signia Assistant and face mask mode. So really a number of ways you can continue to support your patients through, what remains of this pandemic and beyond, well beyond. So all of these tools are really at your disposal to use with your patients. Whether, again, they want a solution to fight that stigma of hearing aids with unique solutions. We can see our stiletto there, kind of in the center next to the active. Actives, as I mentioned, and because these devices are Bluetooth, they do also benefit from face mask mode and Signia Assistant, and they do have directional microphones, which is one thing I didn't actually point out on the slide. So many more exciting things to come too. I hope to have much more exciting news come May when we're talking again. But really, that's kind of just the end of my industry update for Signia. So I'm going to just pull up my thank you slide here and just let you know that, of course, we do have a dedicated team for the area. Katrina Bowden, of course, is the territory account manager. The inside sales rep is Nicholas Brees. And again, my name is Michael Faulkner. I'm the clinical education specialist for Signia. So thank you for staying with me for a few minutes. And with that, I'm actually going to introduce the main speaker tonight, and that's Dr. Jolie Feinberg. She is an audiologist with 36 years of experience, received her BA in Speech and Hearing Science at the University of California, Santa Barbara, her MA in Audiology at the University of Tennessee, Knoxville, and her AUD from Arizona School of Health Sciences. She participated on the original FDA clinical trials for all 3 cochlear implant companies. Her research has focused on pediatric audiology, pediatric cochlear implants in special populations, and diagnostic techniques for difficult to test infants and children, as well as brain plasticity in children. She's a clinical instructor in the Department of Otolaryngology at the Emory School of Medicine and an adjunct assistant professor at A.T. Still University Post-Professional Doctor of Audiology program. Currently, she works as an ENT or at an ENT practice doing pediatric diagnostic testing and cochlear implants for both adults and children. So with that, I'm going to turn it over to Dr. Feinberg.
Thank you, Michael, for the introduction. I appreciate it. Can you all hear me? Everybody can hear me? Yes?
Yes.
Yep.
Thank
Yes,
you.
good. Okay. Okay. So I'm going to share my screen. Hold on a second. Let me open up my PowerPoint here, and then I'm going to get into slideshow mode. Hold on. Sorry. Okay, there we go. Okay, and now I've got to figure out how to share my screen when I just took that. All right, 1 second. I think I'm going to have to. I hope.
Yes, we see it.
Okay. I just want to be sure. Extensive, and I'm going to try to give you some information about the history a little bit, criteria, and some of the different types of cochlear implants there are, and different things that we use to do programming, as well as oral rehabilitation or habilitation. My cat is has a problem with doing things. So my cat is very needy right now. I'm trying to pick my hand. So if you see me wiggling around, it's because I'm trying to avoid my cat. Okay. So I've just a little bit of history about me, although Michael talked to you about that. So I went to UCSB, which is in the top corner there, and you can see the ocean, and it was a terrible place to be because the ocean was right there. Worked at the Bill Wilkerson Hearing and Speech Center was my first job, and I worked on a research project called the Child Project, which was a multi-center project on testing kids for hearing and speech problems. I was really fortunate to get to work with Jerry Northern and Marianne Downs in that, and met her. She was amazing. She was just playing tennis in her 80s, you know, doing all these things. So then I worked at the House Ear Institute, and then I moved to Atlanta to start the audiology and cochlear implant program at Eccleston Children's Hospital, which is now Children's Healthcare of Atlanta. Okay, so I'm going to talk a little bit about the history of cochlear implants because it kind of gives an idea of where we've been and how far we've come, which is really amazing. When you look at audiology as compared to the history of medicine, audiology is a pretty recent addition to the healthcare fields. You look at maybe it really got started in the 1940s, I think, after World War II, where cochlear implants really didn't get their start until the 70s. And so it's a fairly new field, even though the 70s was a long time ago. Oops, that's not what I wanted to do, sorry. Okay, so as early as 1800s, there were people trying to do some electrical stimulation, but they just inserted it into the ear canal, but they did find that people did feel an auditory sensation. In France, I'm not even going to try to pronounce those names. My children speak French, but I don't. They actually placed a wire on the auditory nerve during surgery, and they were able to stimulate, have some current stimulated, and there was a clear auditory percept. In 1961, William House and John Doyle reported about 2 adults with profound hearing loss where they were able to stimulate using an electrode placed on and through the round window into the scala tympani. The patients reported auditory percepts, and the interesting part was the loudness changed with the level of stimulation and the pitch changed with the variation in stimulation rate. And as most of you know, or maybe you don't know, but Bill House is one of the people who really was one of the founders of of cochlear implants, and he's considered the father of neurotology. In 1964, Blair Simmons placed an electrode through the promontory into the vestibule, and they detected changes in duration and perceptive tonality. So this is what one of the earliest cochlear implants looked like. So whenever my patients say, this is too big, I show them the picture of this. So it shows that he had to carry around this gigantic thing. There was no magnet, so it was just a headband on his head, and obviously the woman has to speak into a microphone. So this was the very beginning of cochlear implants. So the first commercially available cochlear implant was the 3M House single channel cochlear implant that the first adult was implanted in 1972. And the device was calibrated on an oscilloscope, and we programmed it by doing a comfort and threshold on one electrode. And we used to take a week to do that. We called it, gosh, I forget what we called it. Anyway, we spent a week with these patients, and we did some testing too. So we were doing basic testing on them as well, but really took a long time, which now, we do it in an hour or 2 hours. So that's what the 3M House device looked like. It was a body-worn processor. The 3M House cochlear implant provided mostly enhancement with speech reading and closed set speech perception, but there were a few patients who got open set, which was pretty amazing. And it was approved by FDA in 1985. And I did read something that said it was approved for children in 1990, but I thought that it was never approved for children, but I'm not sure about that. 3M discontinued the manufacture of the implant. So Cochlear Corporation took over. It was considered an orphan device, and they supported it for about 7 years, but most of the people with single channels have been reimplanted. So this is the first child to be implanted. Her name is, I forgot her name. I hate this. Don't get old. Anyway, she is the first cochlear implant child. And I think that this PowerPoint will be available to you later, because I have a lot of references and things. And if you have a chance to go on YouTube and see this, the stimulation, the first stimulation, and how she learned to speak, and she was really, did very well. And I met her when I worked at House. She was probably 12 or 13 by then, but she did extremely well considering it was just one electrode in her cochlea. So in the 70s and 80s, Graham Clark, Jim Patrick, and Ian Forzer developed a multi-channel implant in Australia, and they implanted their first adult in 1978. Medical device company Nucleus and Cochlear, and then they partnered with the Australian government. And the first commercially available multi-channel cochlear implant, the Nucleus 22, was introduced in 1984. So it was a receiver stimulator with 22 banded contacts. And Jim Patrick still works for Cochlear. So originally it was a headband, as you saw on the other one, even though it was a smaller processor. It was just a headband. There was no magnet at first. And then later they were able to use magnets internally and externally to keep the implant on. So the first thing you see, the wearable speech processor, that was the original speech processor. It was probably about this big. It took 3 AA batteries. So the kids practically fell backwards with the weight of it. And then the first smaller, that was called the mini speech processor, was by Cochlear. And you can see that it still was probably the size of a pack of cigarettes, probably. So Cochlear used a feature extraction strategy, which initially was F0, F2. That was the second harmonic in the fundamental frequency. Later, they did F0, F1, F2, and bandpass filtering. So that was considered, so what they were doing is just extracting the features of speech. And when you look at some of the speech data and stuff like that of what it was actually providing for the patients, it's amazing that these patients can get open set speech discrimination, because it looks like it shouldn't be doing that. And of course, our speech processing strategy have gotten more complex since then. And again, I have a link to Casey. He was the first multi-channel in 1986, and I got to meet him when I worked at the House Ear Institute. And he has excellent speech and does very well. I don't know what's happened to him since then, but I'm assuming he's doing pretty well. So in 1977, as you see, everything started in about the 70s. Ingeborg and Erwin Hochmeier started developing cochlear implants in Vienna. So their first multi-channel implant had 8 channels, and they were working on implanting patients. So their first patient was implanted in 1977, and in 1991, MED-EL introduced the first BTE, which was a big deal because most implants were still fairly big sized. And then they did their first bilateral adult in 1996 and child in 1998. You have to realize that MED-EL did not come to the United States until 1999. So they were able to do all this stuff in Europe, which its equivalent to FDA is not as difficult to get things through as it is for us to get things through the FDA. So that's why they were able to get an early BTE and early bilaterals on both children and adults. So then in 1970, researchers at University of California, San Francisco implanted 3 patients using a gold 2 electrode system. In 1993, Alfred Mann partnered with that program at UCSF to develop advanced bionics. He was already a very successful entrepreneur, and he had one company that did pacemakers, another company that did microaffusion systems for diabetes. He passed away several years ago. So this is this was one of the most interesting, I thought, cochlear implants at the time, but Symbion was a company that actually made the Jarvik 7 artificial heart. And they sort of made a foray into cochlear implants. And they had 6 electrodes that directly connected to the speech processor by way of a percutaneous connector. And you can see that percutaneous connector on that guy's head. And you actually plugged it's kind of like what we see with the Baha now. You actually plugged it in there, and then the person wore a speech processor. The problem is that abutment did get infected sometimes. There was a problem. We couldn't put it on children because they would, go at it. So there was some limitations to this cochlear implant. The processing strategies were different than a feature extraction, but both approaches of feature extraction as well as what was used for inner aid still were quite similar in their results that they got on their patients. So the inner aid product also became an orphan product, and so MED-EL took over that responsibility. And one of the things that they were able to do is, because it was a percutaneous and you had direct link to the internal part, is they were able to do a lot of really interesting research on different processing strategies with those patients. Again, many of those patients have been reimplanted. So FDA approval, of course, in the United States is the thing that most of these implant companies are looking for. Prior to FDA, there's a limited number of centers that can work with these devices. So Cochlear Corporation, their N22 was FDA approved in 1985 for adults and in 1990 for children. Advanced Bionics Clarion was 1996 for adults and 1997 for children. And then the Combi 40 Plus for MED-EL was approved in 1999. And as I said, I worked with all 3 companies on the original FDA clinical trials. So the candidacy in 1980s was that the patient had to have a hearing loss greater than 100 dB and no communication benefits for hearing aids. And I'll talk about that a little bit more, but we don't use that strict criteria anymore. By the year 1998, FDA approved cochlear implants down to 18 months of age. And then by 2000, it was extended to 12 months. And the hearing criteria was broadened. So now I'm going to talk about candidacy criteria. And this is important for people who are working with hearing aid patients because the candidacy has really changed over the years. We now can implant people with a lot more hearing. We can implant people with high frequency hearing losses. You just can't amplify the high frequencies and things like that. So hopefully this will be helpful for everyone. And if you have any questions, put them in the chat and I'll be taking a break. We'll be taking a break. I can answer some then, and at the end we'll have time to answer as well. So for individuals 18 years and older, which is considered adult, it's a moderate to profound sensory neural hearing loss in both ears. Limited benefit from amplification, which is defined by a preoperative test score of less than or equal to 50% speech recognition in the ear to be implanted, less than 60% in the opposite ear binaurally. So there was a group of researchers that kind of redefined that and called it the 60-60 guideline. And the reason they did this was they found that a lot of people who are hearing aid dispensers, audiologists who dispense hearing aids and saw patients only for hearing aids, that they were not really familiar with sentence testing, and they really were more familiar with monosyllabic testing. So they kind of changed it, saying that the best unaided monosyllabic word score of less than or equal to, this really should be aided. I don't know why it says unaided. It should be aided of 60%, and an unaided pure tone average in the better ear that is greater than or equal to 60 dBHL. Yeah, that's the unaided is fine for the other one. So that broadened the spectrum of what kind of testing we could do and what a person would have to have in order to be a cochlear implant candidate. So for children, the candidacy right now is, for most devices, it's 12 to 24 months, and the child has to have a profound hearing loss in both ears and limited benefit from amplification from 2 years to 17 years, severe to profound hearing loss in both ears, and limited benefit from binaural amplification, and testing with the MLNT or the LNT, a score less than or equal to 30%. And if those of you who work in pediatrics, 30% is pretty low. So I'll talk a little bit about what we actually do. In March of 2020, Cochlear Corporation received FDA approval to lower the age of pediatric cochlear implantation to 9 months. In the US, infants as young as 6 months of age have been implanted, and in Europe, the youngest is about 4 months. So in my experience, we've implanted 2 children at 6 months of age. And the amazing thing about that is if you get them implanted that early and get them into speech therapy or auditory verbal therapy, they are almost not delayed at all. It's pretty amazing. So I'm going to talk a little bit about FDA guidelines, because there's a kind of an interesting phenomenon that happens, especially when you look at the guidelines. The guidelines are still pretty strict, and they really leave out a lot of people who could benefit from cochlear implants. So this is a quote from the FDA's website. I'm not going to read it all for you because you guys can read it, but the FDA will look at the clinical trial information. They'll go through their process of talking about it, and they'll ask questions of the company and eventually get to a point where they will approve the device. FDA website is really interesting. So if you do want to have more information about cochlear implants, they actually have some interesting things on the website. They talk about what a cochlear implant is, its benefits, frequently asked questions, what FDA approved implants there are out there, and what educators need to know. They'll also have an area where they will talk about device failure statistics and device recall. So you can look up those things. Now, the problem with the device failure statistics is that not each company uses the same criteria for a device failure. So just keep that in mind when you look at that information. So now I'm going to talk about off-label cochlear implantation. So off-label is when you implant and you implant outside of the criteria that FDA has approved, because every FDA cochlear implant literally has a label on it that says what it's for. And that happens with anything that's FDA approved, medicine, devices, whatever. So very often we implant off-label because we feel like the FDA criteria is too stringent, and it's leaving out a bunch of people who could really do well with cochlear implants. So there was a study done about why people did off-label, and then, of course, people were implanting kids less than 12 months of age, asymmetrical hearing loss that had better than performance of the cutoff for their age, and different criteria, single-sided deafness, although single-sided deafness now has been approved for cochlear implantation. And we have implanted people with a lot more hearing than is approved by FDA, and then with sentence and word scores that are much higher. Because if you really think about it, if someone has a score of 40% or even 60%, that's not very good. And that's really, they struggle a lot. And many people, once they get implanted, will have in the 80s and 90s, not everyone, but many people do. So FDA guidelines are just that, they're guidelines. They're not laws. No one's going to be taken to jail or anything if they they implant off label. The important thing is to know why you're doing it. And so you do have to be, it's not something we do willy-nilly. And certainly if there was ever a lawsuit, they're going to look at that. So I always, if I'm going to recommend off-label implantation, I have a very good reason why I think that patient is appropriate. So that's important to remember. So now I'm going to talk about some different cochlear implants than the general cochlear implants. Most of you probably know a bit about just cochlear implants and how they work, that they have an external processor that takes the acoustic signal and then processes it through the devices, microchips in the external processor to turn it into electrical signal, which is then transmitted from the transmitter, the coil on the head, across the skin using radio frequency to the receiver stimulator, which then sends it to the cochlea. It's a pretty standard one, and for years that's all we used. And then again, as I said, people started trying different things and looking at different kinds of patients who we thought could benefit from cochlear implantation. And for the electric acoustic implants, we're really looking at patients with high frequency hearing losses. And for those of you who do hearing aids, you know how frustrating it is when someone has near normal hearing and low frequencies, and then they really bottom out in the high frequencies, and you just can't amplify it enough for them to really hear the high frequencies. So electric acoustic cochlear implants. The acoustic amplification is for the low frequencies, and the electrical cochlear implant stimulations for the high frequencies. So the main thing that has to occur is a surgeon has to do the procedure with hearing preservation in mind. So over the years, the implant companies have recommended different techniques, and they have also put together different electrodes that will help with this preservation of the hair cells that are still there. Because of course you're shoving an electrode into the inner ear, and that can obviously damage the hair cells. So they try to do surgical techniques for hearing preservation. So the benefits of electric acoustic cochlear implants is that they're significantly better speech understanding. There are things that the implant cannot process well. It just doesn't. It just, right now, maybe in the future we'll be able to, but we're not able to process that information quite the way a normal hearing does, acoustic hearing does. And so music in particular. So people who have that low frequency hearing find that they can really enjoy music much better with that low frequency natural hearing. Better hearing and noise, greater satisfaction in hearing, less effort for communication, and then more natural perception of low frequencies. So if you have a patient who's really struggling with hearing because their hearing aid cannot amplify the low frequencies, then this can be a really great option for them to be able to allow them to communicate better and get more natural sound with their hearing aid. Now, unfortunately, sometimes, even if a surgeon uses their best techniques for hearing preservation, the hearing will not be preserved. And so then the person is treated like a regular cochlear implant patient. Sometimes the hearing is still there, but it does get worse, and sometimes it will get worse over time. So it's not a perfect situation, but it certainly has been helpful for patients who do maintain that low frequency hearing. So here I'm going to talk a little bit about each company has something that they use, not always a complete acoustic electrical implant, but I'll talk about the different things that each company has and show you a little bit about the audiograms that you'll be able to use for candidacy. So the cochlear nucleus is called the hybrid, and it's for unilateral use in patients aged 18 or older who have residual low frequency hearing and then severe profound hearing loss in the high frequencies. So that's changed a little bit, and some people are using it for bilateral hearing losses, because at that point, why would you only do it in one ear? So you can see that the fitting range, what the fitting range is, and then down there you can take a little bit of a look at, is there any way I can get like a point? Oh, there's my pointer. You see that? So this is the actual implant. So it really is basically the same cochlear implant, and it just adds the ability to either have a regular ear mold, or you can have the slim tube. So the MedHel has the EAS, or the electroacoustic stimulation implant, and there's minimal to moderate hearing up to 750 and sloping to a severe profound hearing loss. They also, no malformations or obstructions of the cochlea, so it can't be a Mondini malformation, although I don't know if you'd really have that much low frequency. No external ear contradictions for using a hearing aid in the ear canal or hanging on the ear either. Stable air conduction thresholds. And of course, even though they might have stable air conduction thresholds, that could change with implantation. No more than a 15 dB airbone gap, and the monosyllabic score is less than or equal to 60% at 65 dB SPL. And they have to have adequate motivation and realistic expectation, but that's pretty much with any cochlear implant. It's really important for the patients and families to have realistic expectations of what it's going to sound like and how it's going to work. So they did expand the indications for EAS, and with no hearing loss up to 250 at 250 and at 5,500 hertz, and higher, they have a profound hearing loss, so it can really dip off much more quickly than the original. So this allows recipients to benefit from some of the little bit of their natural residual hearing, even if they have a profound loss or a significant loss at 500 hertz or higher. My cat is, and it's kind of hard to see down here, but there is a picture of it. So you can see that that's a really bad picture. I'm sorry. There's an ear mold there. So that's how it's connected. So Advanced Bionics, they offer an all-in-one cochlear implant and hearing aid option. And what it really is it's an ear hook. It's just an acoustic ear hook that attaches to the implant and then is programmed along with the cochlear implant. And it's programmed within the AB software. All of these are actually programmed within the software. There's a hybrid mode for cochlear and EAS mode for MedHel. So now I'm going to talk a little bit about bone conduction implants. So we're all familiar with the reasons why you would consider bone conduction devices, either single-sided deafness, conductive hearing loss, mixed hearing loss, or atresia. So I'm probably telling you stuff you already know, but bone conduction, of course, can stimulate both sides, both cochleas. And you can see here that this person has the bone conduction device, which then can also travel to the other side. So there are two main types of bone conduction. You have passive and active. So passive bone conduction uses a mechanical amplification through the skin. So some sound energy is lost as it passes through the skin. Certainly we have that with bone conduction hearing aids that are just sort of, headbands that are just put on the head, and the headband can move and it doesn't always give the best acoustic sound or clarity. Bone conduction hearing aids may have changed, but when I was fitting hearing aids on children with bone conduction, many of those kids rejected them, and they really didn't like them because it doesn't give enough amplification. The amplification isn't clear enough for most of them. That's been my experience. Active bone conduction is a mechanical sound energy that's transferred directly to the bone, providing very good sound quality and more powerful amplification. So percutaneous and passive transcutaneous cochlear implant systems usually integrate the mechanical transducer into the auditory processor, which can cause feedback. This can limit the amount of amplification range. So there is feedback as well in bone conduction implants. So now I'm going to Cochlear Corporation actually has two different bone conduction implants now. One is a passive, one is an active. So the Baha is one that some of you might be familiar with, and actually originally Baha meant bone anchored hearing aid, but they don't call that anymore because when they did, insurance companies wouldn't cover it because it was called a hearing aid. So they've kept Baha, but they don't use bone anchored hearing aid. So the Baha 5 can fit people with hearing loss up to 45 dB, sensory neural hearing loss. The Baha Power is up to 55 dB, and then the Super Power, as you can see here, it really looks like the cochlear implant, but it has an additional part that works on the head. So, and then the Baha 6 has just been announced. I don't have a lot of information about it, so, but it is coming out. So one of the things about cochlear implantation is how it's connected. And Baha has both types of connections. So the Baha Connect is, as it sounds, it's a actual abutment. So if you can see here, that's what's planted here is, oops, the Connect, sorry, is the abutment is here. So that's actually, it's kind of like what the inner aid was like, and you can actually see a little thing and you actually snap it into the person's head. It always feels weird to do that. I always feel like I'm going to hurt them when I snap, but it literally snaps into their head in the little percutaneous thing. So it's the area has to heal and before the implant can be used and put on. But the nice thing is that all the upgrades have been made with the same percutaneous plug-in so that you can then upgrade to new devices as things get better. They've also introduced the Attract system, which is actually a magnet. And again, this is a little less power because of the fact that you've got that space in between the device and the internal part. So this is one of the newest bone conduction devices from Cochlear Corporation. It's called the Ossia, and it's placed under the skin and works by bypass. Well, of course, obviously works by bypassing the ears. The implant attaches to the titanium implant that is implanted under the skin for cochlear. The implant provides actual integration with the bone. It's called osseointegration. So the internal part actually kind of grows into the bone, or the bone grows into it. And so then it really has a good, it's well situated and also provides a better vibration and amplification and clear signal from the device. And this is the external device, which looks kind of like the Kanzo, for those of you who are familiar with a single device of cochlear implants. So, as I said, it's a transducer that vibrates, and it is osseointegrated, so it really provides for better, more reliable and consistent hearing performance, and it can fit a sensory neural hearing loss up to 55 dB. And I'm assuming that eventually that will change over time, as they always do. They get more power because this is a fairly new device. It's not been around for very long. So MED-EL has a device called the Bone Bridge, and it is also active bone conduction implant that is fully implantable under the skin, which has a direct drive amplification with transcutaneous technology. So this is also an active bone conduction device. Their Samba 2 speech processor is also a single doesn't have any, it's not like a traditional cochlear implant goes behind the ear, and it wirelessly transmits the signal to the implant. It actually has dual microphones that are separated so that it allows for, they can use different types of technology to focus and use beaming form and things like that to allow for different situations like in noise. And it minimizes any issues with feedback, even at high gain levels. So this is something that the ad here is something that's fairly new. And at the clinic that I work at, I do the cochlear implants, and there's another audiologist who does hearing aids, and she's actually been using, so this isn't technically an implant, but I thought I wanted to talk about it because this is kind of a, new things that people are looking at. And this can also be something that can be used until someone becomes eligible for surgery, or to give them that feeling of a bone conduction device and whether they actually do want to go through surgery. But we certainly can use it on children because they are not eligible for surgery until about 5 years of age. So the cool thing about this is it's not a band on the head, because that is a problem for some kids. First of all, the band moves around. And then when you ask a young boy sometimes to wear it, they're not going to tolerate a headband. So this allows for bone conduction, use of bone conduction without any headbands. It uses an adhesive adapter, which applies no pressure against the skin. The single-use adapter is applied behind the ear and can be worn up to 3 to 7 days, plus you can shower in it. So it basically, you're not gonna be able to see this very well, but it basically goes right behind the ear, just where we put the bone conduction oscillator. It sticks there. And we have not had a lot of problems with people having it fall off. I have heard some complaints on some of the Facebook groups that some people have. And so I want to present that as a possibility, but we've had excellent experiences with it. We've done over 20 people with adheres, and it is water resistant, so sweat shouldn't cause too much problems with the adhesive coming off. So the only thing is you have to have a normal bone line. So that it obviously there are certain patients that won't be appropriate for them. And then Med-El did have what was called the Vibrant Sound Bridge, and that's no longer being implanted, but Med-El is still supporting the recipients that did have it. And I think the Bone Bridge has really kind of replaced that.
Jolie, we do have a question.
Oh, we do have a question. Okay.
Yeah, Lacey, do you want to ask the question directly, or do you want me to read it?
You can read it.
Okay, so the question was, is there an external portion of the bone bridge, or is it all internal?
There's external, let me go back and show you. There it is. This is the processor. So it doesn't show them together. This is what's implanted under the skin, and this is the processor. So
Got it.
Does that answer your question?
Yes.
Okay.
Thank you.
So in all these devices, there is an internal and there's an external, as it is with cochlear implants. There's something implanted and then something put outside. This is one thing that's kind of interesting when we talk to patients about surgery, is very often they think surgery is going to fix everything and they're not going to wear anything again. So if they're a hearing aid users like, oh, we don't have to wear anything, it's like, no, you do have to wear something, both with bone conduction as well as with cochlear implants. And that's a big disappointment. There has been, I'll just take a quick little side thing here. So there have been forays into totally implantable cochlear implants. And Cochlear Corporation has actually been working on it for quite a number of years. In 2013, when I went to Australia and visited Cochlear Corporation's headquarters, we actually got to meet one of the people who was using they call it the TICI, T-I-C-I, totally implantable cochlear implant. And I think they've implanted 2 or 3 patients. Unfortunately, it's really not commercially ready yet. There's been quite a number of issues with totally implantable cochlear implants. Battery life is a big one. When you think about if we're implanting children at 1 year of age and those batteries won't last forever, like any rechargeable battery, it doesn't last forever, and to constantly be having to re-implant. And right now, I don't know what the lifetime of a battery is, but most batteries, I think, like for a pacemaker, it used to be 5 years, maybe it's 10 years now, but even 10 years, every 10 years, worried about breakdown of the skin, to having to constantly go back in and use those batteries and replace the batteries. The other problem is the microphone. So the microphone under the skin does not give good fidelity. The patients don't hear very well. So the man that we met said that he can wake up in the morning, he can take a shower and hear while he's taking a shower. He can go down, have coffee with his wife, but when he's ready to go to work, he has to use an external processor because the quality of sound is just not good enough. Now, Med-El has very recently implanted a couple of patients with their TP, and they haven't talked about it at all, which is kind of interesting. I saw it on something, it popped up on something, and I've looked into it, so I haven't heard anything about it yet, so I can't really tell you about it. And the way, excuse me, so I don't know what they're using as far as the rechargeable battery and what they've done with the microphone. I mean, there's been some talk about putting the microphone in the canal, things like that, but it's something that's probably going to happen in the future. The interesting thing is we as hearing people think, oh yeah, wouldn't you want to hear all the time? Nearly all of my patients who were basically cochlear implant hearing is the only hearing they've ever known. They've been implanted very young. They don't know any other sound. When I say to them, how would you like to hear all the time? They're like, nope, don't want to. They really like taking off their ears. They love having that, just taking off their ears and having complete silence. Because and this is hard for us as hearing people to even imagine. They don't hear their swallowing. They don't hear nothing. They don't hear their blood rush. They don't hear anything. It's complete and total silence. And many of my patients love that. They like just taking those ears off when they're studying, when they're just trying to read, or if they just when they go to bed. So that's what's interesting is that it may not be everyone wanting that device. So, okay, so let me go back. Let me catch up a little bit. Okay, so Oticon Medical has what's called the Ponto, which is their osteo integration device. And there's, as I said, it's an osteo integration, so it is an active device. And the titanium implants actually merge with the human bone, which I think sounds very interesting. So what it's able to do is that, so this is a little complicated, and I'm not sure that I really completely understand it. So, but somehow they're able to use an oscillating laser beam that increases the strength of the bone to implant interface by more than 150%, making it stronger than the bone itself. So I can't really say I totally understand how they do that and this description here, but I don't necessarily think I understand exactly what it is, but it's really interesting that it actually really is in there and it's very strong and it integrates with the bone. I'm not sure what happens when they have to reimplant, but so the Ponto has two different styles, and the Ponto 4 is the more recent one. They have a regular Ponto, Ponto Power, Super Power, and you can see Ponto 3 is 45 dB, Power is 55 dB, and the Super Power is 65 dB, and that's actually not quite the size that they are, but it's probably close to that. And then the Ponto 4 has a standard fitting range up to 45 dB HL bone conduction average. So, and they also, all these implants come in different colors now. Back in the old days, like with hearing aids, there was only beige and that was it, but they come with lots of different colors. And they also come with like skinnets and other fun things that can make it fun for kids. Again, children can't be implanted with any kind of abutment or anything until they're 5 years old. So that's when they've often used a soft band or the adhere is one of the things we've started using. So this is interesting, and I included this. I don't really know anything about this company, but several times their name came up when I was seeing things on Facebook and when I looked up things about bone conduction implants, and they do talk about this one, and it's called TransEar. And so this is I swiped this from their website, so I should have done that. But anyway, it's basically what you'd expect. But the interesting thing is, so I'll show you what it looks like. I don't know about you all, but it looks like a hearing aid from 1970 or 80 and a huge ear mold. I honestly, with all due respect to TransEar, I can't imagine very many patients wanting this device. I don't know, but I guess the benefit is that it fits like a hearing aid so that you don't have a soft band or anything like that. But I just wonder about how many patients are actually using this. So there was one other company called Syphono, and I could not find them anywhere. So I think they must have gone out of business. And I'm not sure who has taken over, because then they become an orphan device, and I'm not sure who has taken over that device, which company has done that. Okay. So I'm going to talk a little bit now about single-sided deafness. And this, so back when in the dark ages, when I went to school for my master's degree, we pretty much thought, you can hear out of one ear, you're fine, no worries, go home, see you later, and just really blew it off as being no big deal. And we didn't work. I mean, we just would say, okay, you've got hearing loss in your right ear, make sure people are on your left side, and go home and enjoy life. But Fred Bess and Anne-Marie Tharp did a study on 60 unilateral hearing impaired children and found that that was not the case, that these kids do have issues and do have problems, particularly in school. So the results of the test indicated that about a third of the children with unilateral hearing loss had failed at least one grade. 50% of the children studied had either failed a grade or needed resource assistance in school. So children with unilateral hearing loss performed much poorer than a matched group of children with normal hearing loss in both localization, which of course makes sense, localization, and syllable recognition. Their conclusion is that these kids really have more problems than we previously thought. And actually, Bess and Tharp, as well as some other people, have written lots of different papers on this about the use of FM systems, the use of different cross hearing aids, things like that, and how well those work for children who are struggling with their unilateral hearing loss. When I was being trained, the cross hearing aid was the most commonly used, and a lot of patients didn't like it. I'm not sure. I think some patients now with the new cross aids like them better, but I find that a lot of people don't really find that they're as helpful as we would like them to be. And certainly FM systems can be helpful for just reducing that signal to noise ratio for the child in the classroom. So there are about 60,000 people in the US who are born with or require single-sided deafness. So certainly we've done, as I said, we've done a lot of things to try to help them benefit from some kind of a hearing device, because mainly we want to make, obviously, listening easier and more comfortable, but also having one ear is really a problem in noise. Or if someone comes and sits on your bad side, it's really hard for the person to hear that person. I know I'm preaching the choir, you all know this. So the current hearing device options there's quite a few of them now. So you can use a bone anchored implant, the cross or the bicross hearing aids, cochlear implants, the Adhere or the Transhere. We'll talk a little bit about cochlear implants in a minute, but that's a fairly recent addition to single-sided deafness options. So they were looking at what happened with children who received a cochlear implant with single-sided deafness. And these kids were a little bit older, mean age of 6.6, with a standard deviation of 4 years. So they did implant some kids as young as like 2.5. Most of these children showed clinically meaningful improvement in speech perception and noise, which is good, and in quiet. So obviously the kids who had longer duration of deafness didn't do as well. There was statistically significant improvement in sound localization, which is good, and that we would hope for. Patients with acquired single-sided deafness and shorter duration of deafness did better. So we know this from our experience with implanting completely deaf children with cochlear implants past about the age 3. I think 3 or 4 years ago, Anu Sharma came to speak at GAA, I think it was 3 or 4 years ago. And she's really the queen of looking at brain plasticity and when is the best time to implant. And really implanting a kid before 3 years age is really the best. Now, if they've got hearing in one ear, I think we have a little more time, We don't have, I mean, you still want to implant them before 3, but you don't necessarily have to implant at 6 months of age. Wouldn't be bad either. But if you start implanting kids 6 and over, then that deprivation in that ear can make it so that they don't do quite as well. And then adults with long-term single-sided deafness, that can be an issue as well. Now, there's certainly some people who will have a sudden hearing loss in one ear, and then a cochlear implant can be very helpful with that. So as I said, this is a fairly new thing happening, and just beginning to implant patients with cochlear implants for single-sided deafness. And it just got FDA approved fairly recently. So now I'm going to talk about bimodal hearing. So there are patients with asymmetrical hearing losses, of course. And as you saw with some of the criteria, we actually sometimes wouldn't implant the worse ear if the better ear is too good, which doesn't really make sense, but that was what was happening back in the old days. So what some of the cochlear implant companies did is they started working with hearing aid companies to work together so that the two, the implant and the hearing aid, can work together for these patients so they can hear better and they can communicate, they can use the same app, so you can coordinate them better. So the first thing that people usually have asked me, patients who we've recommended bimodal, isn't it hard for the patient to figure all that out in the brain, that they're hearing 2 different signals? And that's very true. They are hearing 2 different signals, but the brain is amazing on how it is able to mold those 2 different signals and actually provide really good hearing for these patients. And I don't have that many bimodal patients, but certainly I don't get a lot of complaints about that. And we certainly have that even with cochlear implantation, especially in the early days when we only implanted one ear and then we implanted the other ear much later. And of course, that's going to be different sounds as well. But the brain is really amazing. Seems to be able to adapt to that ability, adapt to being able to take those 2 different signals and work them together. And actually, they can really be helpful for giving some of that low frequency hearing on the hearing aid, or some of the more natural sound in with the electrical sound, and they work quite well together. So I'm going to talk to you a little bit about different, and again, each company has, well, I know it doesn't, but so Advanced Bionics is, I don't know if most of you know this, but Phonak and Advanced Bionics are actually part of Sonova. So they've been working together for several years now. And so they were one of the first to really get that link between the two, between a cochlear implant and a hearing aid. So their voice stream technology, which basically allows the two to communicate with each other. So the cochlear implant, the NIADA CI and the NIADA Link, actually share sound signals, so that when one here has a better advantage, like if someone comes on this side, you also get that benefit on the other side. They also can hear on the telephone with both ears, duo phone, so they can manage that. Now with the new cochlear implant, the new Marvel, that's a direct to Bluetooth to your phone, and that will, when the patient downloads the app, they will be able to pair both their hearing aid and the cochlear implant. So then they have all the benefits of, volume control, different changes of different programs, and listening to music will go to both ears, and a phone call will go to both ears. So that really allows them. We didn't have that for a long time, and I think a certain number of patients stopped using their hearing aids because I think it may have bothered them a little bit. I don't know, but this way it really gives them dual hearing, and the hearing aid and cochlear implant work together so they can use each other's technology and information. So in a noisy situation, they may make some adjustments, like in auto ultra zoom or in auto sense, using both the implant and the hearing aid. So as I said, the Phonak NIADA Link and the AB NIADA CIQ90, which is the previous model, those work together. And now with the new Marvel, which just came out about a month ago, which is called the M90, the AB NIADA CI M90, will communicate with the Phonak Link Marvel. So again, you can have those. And we can actually, with NIAIDA Q90, we have to program the two separately, although there's a pairing information. So when you go to program the hearing aid, there is a pairing number that you enter in so that they can work together. But the new Marvel is actually programmed as part of the NOAA platform. So you can work both of them together, and they're both the same platform, which really makes it a lot easier. So, and Cochlear Corporation and GN Resound have now linked together to do the same thing. And so the Nucleus 7, the Canso 2, or the Canso 2 can speak with the Resound hearing aid and can use the same application. So I just had a gentleman who I programmed with this. So he uses a hearing aid in one ear and an implant in the other. And he's a fairly new user with the cochlear implant, and we were able to link them together. And then his wife sent us an email just bubbling over saying how much he loved it. And this is a man who sadly had lost his hearing fairly recently from meningitis. So my coworker works with the Resound hearing aid, and this is not on the same platform, works with Resound hearing aid, and then I pair it to his cochlear implant, and now you can use just one app and to control it. So it's not quite as easy to program. So I do work with my coworker to have her program the hearing aids in some cases. Some cases I do actually program the hearing aid as well. So they collaborate, and so that everything streams to both ears, which I think is a huge benefit. So MED-EL does not work with any particular what's it called, hearing aid company. So they don't have that. So it looks like we're kind of halfway through here because I started a little bit early. So actually we're almost, I think I started right after, we might be almost an hour in. So I don't know if we want to take a quick bathroom break or water break or anything like that. I mean, I'm happy to continue on, but if people want to take a quick break, we want to do
take just a quick break, maybe
okay.
It's 8:15 right now. Why don't everybody take maybe a 3 or 4 minute break, be back by 8:20.
Okay.
And but real quick, there was one other question.
Oh, good.
So
Okay.
asking if the Ponto 4 released their power and superpower products yet?
Not yet. At least the last time we talked to the rep, she came a little while ago, and they're working on that, and that should be released fairly soon. Yeah.
All right, well, why don't we break till 8:20? So if everybody wants to hop back on at 8:20.
Okay.
All right, great. Thanks. If you want to go ahead and start back up.
Okay, I sure can. All right. So the next thing I want to talk about is ESRT and ECAP used in cochlear implant mapping. So the electrically evoked stapedial reflex thresholds, or ESRT, are an objective measurement that can sometimes be used to program the upper limits, which we call the C and M levels, the most comfortable levels or comfort levels during cochlear implant programming. So the ESRT is observed when there's a change in the static admittance of the ear canals, which is like a reflex, in response to electrical stimulation through the cochlear implant. This is used by actually programming the patient while they're also attached to an impedance bridge. on the reflex decay setting. So what it does is you're going off and you do a simulation, you watch for a deflection, another beep, and watch for the deflection with each beep. So it's defined as the lowest amount of electrical stimulation that results in a 2% deflection from baseline. So the ESRT has been found to be highly correlated to behaviorally measured CNM levels. ESRT should be obtained using the same stimulus used during behavioral programming. So you have to check to make sure that the ESRT program is using the same stimulus, because otherwise they're not going to coordinate. They also have to have normal tympanometry, no tubes. So for kids, it's a lot harder to do because often they have middle ear stuff or they have tubes, so that can be more of a problem. Adults are easier. Of course, they'll stay still better because a lot of times with kids, even if they're being cooperative, they're moving their heads around. They're just, they're not necessarily going to sit perfectly still. So it's really hard sometimes to see those. So even with somebody who has normal tympanometry results, you might not get an ESRT. If you don't get an ESRT, it doesn't mean there's anything wrong per se, but so that it's never anything to worry about, but it can be really helpful as one of the more objective measures for cochlear implantation. So the next thing I want to talk about is ECAP. And this is something that each company has their own ECAP program, and I'll talk about each company's program. And what it is basically is through the way I describe it to my patients, it's like an ABR through your cochlear implant. This is basically electrical evoked compound action potential through the cochlear implant. And so, which of course is the waveform of the ABR. So when you're running it, you can actually see the N1P2 tracing, sorry. I'm sorry, it's getting late. I might get my words out. So the ECAP is recorded from the electrodes. So you can do ECAP on all the electrodes or certain electrodes. And it gives you some idea, well, I'll explain it later, some idea. Certainly, even if I don't use it for programming, I always do it on every patient. I sometimes will do it on initial stim, but sometimes that's a problem because when you first electrically stimulate, the impedances are initially pretty high for the patient because there's that connection between the basilar membrane and their electrode. There might be bubbles there might be some debris. So with stimulation, usually that impedance will go down. And if your impedance is too high, you won't get an ECAP. So sometimes I don't do it on the first initial stim, but I try to do it within the first month or so because it can give us really good information. So what kinds of things we can use it for? It's objective verification that the auditory nerve is functioning. And again, if you don't get an ECAP, it doesn't necessarily mean that there's something wrong. I find that many of my neuropathy patients don't have ECAPs. So majority of my patients do, and sometimes they won't have it on the basal electrodes or something. Sometimes that will be a difference, but usually you can get at least some. And I don't do it usually on every single electrode. I usually do it on the odd electrode or pick 5 or 6, depending on what my needs are. And it does provide assurance to the patient and family. So if I'm doing ECAP and I can say, oh, they look beautiful, but that's even a little bit of a problem because you can certainly have someone who has ECAPs and they don't do well with their cochlear implant. So I have to be a little careful about that, but I do, we'll say, oh, it looks good. So the connection looks good. And that's really all I can say. I can't really say anything else than that. It does allow us for a baseline measurement. And the reason I do it on everyone is if someone down the road starts having difficulties, like they're not hearing well, or their implant doesn't seem to be working properly, and we're wanting to know what's happening on the internal device, we can repeat the ECAP and see if it's changed at all. So that's very helpful. So programming the speech processor, this varies with companies, is from my experience, but we'll talk about that as I talk about each company. But it certainly can determine audibility because if you get an ECAP measure, means it's audible at that level. It should be audible at that level. And again, verification and confirmation of questionable behavioral responses. And this one, if you keep a kid interested, you can do the ECAP. They don't have to be perfectly still, of course. They just have to wear their implants. So that makes it a little easier to do than ESRT. So this is what the, this is what the ECAP looks like. And for the most part, the thresholds will fall between the threshold, the T level and the CNM level for majority of patients. There are differences in the manufacturers and how they stimulate and the kind of stimulation they use. And of course, each device has slightly different parameters. So, but that is what we're looking for. So I'm going to talk first about advanced bionics. I'm going alphabetical order. They call theirs neural response imaging, or NRI. So I'm not going to repeat everything because they all use this first paragraph is pretty much what everybody uses. So they have the N1, P2, as we say, and they calculate the peak to peak amplitude difference, and they plot that as a function of current level. And I'll show you what that looks like. The amplitude growth over time. So as you get louder, so when you start your simulation at a medium level, really not too low a level, and then you increase it and you watch how the response gets bigger, and then they calculate, the program will calculate your threshold, your TNRI. So for advanced bionics, if the TNRI is less than 200, you set your maps at TNRI. And at 20% above and 40% above for TNRI between, so you set maps at 20% above and 40% above. So you give two different options. And then for TNRI that's between 200 and 300, you set the TNRI at 10% above and 15% above. So you try different things. Now, there was some research by at Overstreet that looked at, for advanced bionics, that the TNRI was about 25% of what we would consider the M level. But I could not find that paper. I looked and looked and looked, and I couldn't find that paper. So I can't give you details on what that was, and I may even be getting the numbers wrong. But with AB, I often do use the NRI to help me with programming. It will be a starting point, and usually it gets off at some point. But occasionally, if I have a patient who's struggling, what I do is I try different things. And sometimes I try things that seem counterintuitive. But one of the things I do is I will go and try an NRI map. And what I do is I put their M levels at where NRI is, in that shape of what NRI is, and then, of course, tune it for whatever is comfortable for them. And I've had a few patients sometimes say, oh my gosh, that's the best map ever. Why? I don't know. But I use it for something. But it does give me some idea of what they're hearing. And so I feel more comfortable using NRI for M levels than some of the others. So this is what what it looks like. And if you can see down here, oh, there we are. So you can see down here, this is the progression of the loudness. So you can see the clinical units. It starts at about 150 clinical units to go to 225. And here you can see the that progression, and your TNRI is right here. So it calculates that all for you. And it does show you, as you're doing this, it will fill in the circles if you got a response. It will put an X if you don't get a response. So here they do 4 electrodes. For AB, I do odd electrodes for no particularly good reason. So that gives me a good span of information across the board.
Julie, I have a question for you.
Oh, yeah, sure.
I'm not as familiar with AB as far as CI goes, but I'm just wondering with, I know with cochlear, we had C and M levels, and with MED-EL, you have the M levels. With AB, are they using M and C levels, or are they more like MED-EL, or it's just one level?
That's a really good question. And let me take a little bit of a minute. So technically, Cochlear Corporation has always required you or talked about when you're programming, you should get T and C levels.
Oh, yeah, that's what I mean. Sorry.
Yeah, no, it's fine. No big deal. No big deal. I know, no, I knew exactly what you meant. Don't worry about it.
Sorry.
I just translate it all in my head. So T and C. Technically, Med-L and AB would say don't do that and just leave it at 10%. I don't always agree with that. So very often I will get thresholds on AB and Med-L. Now, the last time I was talking to our Med-L rep, she said with the new device, the new internal device, they're finding it's really is a good idea to make Ts. You're not going to keep it at threshold, but you're going to go a little below threshold. And so they are now saying sometimes, definitely, if someone's having quality issues, I will always check Ts. But I very often, except on children, of course, it takes a while to be able to do that, but I try to check Ts. Now, I have occasionally checked Ts and have someone go, oh my God, that sounds horrible. So you have to be flexible. But certainly with Cochlear Corporation, I'm very, if someone comes in and says, I can't hear far away when it's T levels. So, but I find that for all three companies, Ts can be very, very helpful. So, but they're good.
Thank you.
Excellent question. So again, the software does the same thing. I'm not going to go into that again. I put this in, but something for the slide. So there's this called neuroresponse telemetry. So I find for Cochlear that there isn't a really good correlation between NRT and thresholds, and C levels, comfort levels. I actually did I think it was Audiology Online where they basically said that. Now, I know some people who do use them, but I find that they don't correlate very well. But they do tell you what's audible. So that does help with young children. But I still do it just because it's a good baseline measurement. So this is actually not what theirs looks like anymore, and I could not find a new screen of theirs. So looks, as I said, very similar to the others. And you know what? Is this it? Yeah. So very similar, but their new program looks different than this. Med-L has the auditory nerve response telemetry or ART. Works the same way as the other two. And I'll show you a little bit about there. So there, initially, when we started doing ART, it was like Cochlear. It really didn't have any correlation. You did it just because it was a good thing to do to kind of get an idea of what was happening with that patient, and so you could use it later. But more recently, they've done some research and found that ART can be correlated to M levels. And so they actually have that as part of the program. I'll show you that in a second. So you can see here, they actually use N and P for their calculation there. And you can see the relationship between all of these and these. So they actually use quite a number of stimulus levels for their calculations. And then one of the things that they've done recently is they have what's called auto ART. Sorry, I always get them mixed up. I can't tell you every time I say them wrong. Auto ART, which basically you set them up and they go through each electrode and it picks your ART level for you, and then you can make a map related to the ART. Again, it's a starting point. It's a great place to start, and you get you kind of in that range, and then you can go from there. And people's maps change so much over time. And I mean, I have some patients whose map don't change as much, and I have other patients whose map change constantly. I have a set of sisters who are now, they're adults essentially. They come all the time. And they're just, but this, I love seeing them, it's fine, but it's really interesting how their maps change so much. And then other patients, they don't. But you're always going to have to be looking at maps and changing them and try to figure out what will make someone hear better. And so this is what it looks like here. And again, that's what it makes the program. Okay. So I'm going to talk a little bit about remote cochlear implant program. And of course, with COVID-19, that's changed everything. Cochlear implants has been a difficult issue with programming remotely. Now, there have been some situations in which, and I'll show you a picture of that, where people set up different things in different countries, in different parts of the country, but you do have to have the hardware there, the software and the computer and the hardware. And that's really what makes it difficult for us to do it from home, people's homes. And that, I guarantee you, especially with COVID-19, that is going to happen. And there's going to be ways in which you can plug yourself into your computer and you can talk to you can, FaceTime your audiologist and you can do programming that way. Or even they've actually done some testing with people going in and being able to program themselves by setting their own T&C levels. And a map is made from that. So there's a lot of different things. Of course, then I won't have a job, but anyway, that's not good, but anyway, that's fine. So this is going to happen. It's really, it's the way of the future. And people living, people right now who don't live near a metropolitan area are really in a difficult situation when they get a cochlear implant, because, not every place has an audiologist for hearing aids and hearing testing or ENTs. Cochlear implant centers are, often few and far between. So it can be difficult for patients. Here in Georgia, we have most of our cochlear implant centers here. There's one in Macon. And I don't know if Augusta and Savannah, but that's not very many. So anyone who lives in anywhere else, they're going to have to drive several hours for cochlear implant programming. So this is why this is a really, really good thing to have, that we can, so hopefully, as I said, and then teleaudiology, because of COVID-19, teleaudiology was approved for many insurance companies, including Medicaid, I'm pretty sure, as a billable procedure. So I hope they're not going to step back on that once everything goes away. I just imagine they'll just leave it. And because it helps for people, as I said, in remote or rural areas where they have no local cochlear implant program or even a hearing aid program, or even to see an ENT, elderly patients, people with transportation challenges, and anybody with medical issues where they're either in the hospital or they're autoimmune, they don't want to come around to a clinic. So there's a lot of reasons that cochlear implant programming remotely would be really helpful. I know Bill Shapiro at NYU has set up some programs where he's actually done them in other countries. They have to have the programming stuff there, but he can help with them with programming. If you don't have trained audiologists in a certain area, if they can get the hardware and software there, then they can be done remotely. So this just shows the setup, which is pretty clear, but it can really help people who don't have as much experience to help another program with their mapping. And there are also ways in which you can share, you can take over someone's screen and share, that screen, and then you can help them manage the map, and you can see the map and see what's going on and see if there's something that you think they need to change. So that, I think, is going to happen in the very near future. So now I'm going to talk about oral habilitation or rehabilitation, depending on if you're an adult or a child. So one thing we know for sure, and there's been tons of studies done on this, at least with children, you can't just put an implant on a kid and go, bye, see you later, and they go off and running and they hear. They have to have oral habilitation of some sort. And that part is, again, sometimes a challenge for patients, although they're really doing a lot more teletherapy because of COVID-19. I know Auditory Verbal Center is doing a ton of teletherapy, which has been great for some patients who are having to drive. And then, again, they've also worked with patients from other countries to do teletherapy, which is fabulous. And that really allows for so many more people to benefit from the training. And as I said, kids have to have that in order for them to become listening spoken language users. And even if they're going to sign, there's no reason to get a cochlear implant if you're not going to learn to speak and listen at some point. I mean, that's my opinion, and I know some people might disagree with me, but if you have an auditory device, you want to use that. And most of my patients who do sign, they also speak and listen, and they really like their implant, and it helps them. So I'm going to talk a little bit about what each company offers and some of the other places that you can. And there's a lot of free stuff, which is really great. There's a ton of free stuff for patients to go and use. And I also tell patients, go to each company. They don't know that you're not there. You can go on every company's website and download their stuff and play their games and do everything and do auditory training. The other reason we do auditory training for adults is if they get reimplanted, sometimes they will need to go back to do some auditory training again to get them back together. And of course, when they first get implanted, I think we used to think that adults didn't need anything, but they really do. And this can be really helpful for them to become better listeners. And then they also gives us information about what they're hearing and not hearing, so they keep track of some things. Well, I wasn't hearing words with B in them very well. So that helps me be able to program them better. So Cochlear Americas has the communication corner. And I hope we're going to make the PowerPoint available to you all. So you'll get all these websites. And There's a music program, telephone program. So there are a lot of things will take you through guided activities and guided listening, and then help you score it and things, and then make it harder and harder as you go along. Advanced Balance has the listening room, and there are listening activities for all ages, for every child of different ages, and adults. And a lot of times with my adults, when they first get implanted, I said, start at the baby level. Don't go into the adult level. Go to the kid level. Start with that, because that's really where you're at. A lot of times you're not hearing much better than that. You're just hearing presence and absence, or very, very little discrimination. So start with the baby stuff and then work your way up to the adult stuff. And that makes it less frustrating, because you start with the adult stuff and they're expecting you to hear words and you can't hear words, you're going to get really frustrated. So BEDL has Bridge to Better Communications. And again, they have a lot of really fun little games, like computer games with listening to cow noises and horse noises and things like that. And again, I had one patient who, she was on that program, and she'd email me every once in a while. She'd go, I'm 4 years old now. I'm in primary school now. I'm 7 years old. As she progressed along, she was getting better and better and telling me what age she was at. So Angel Sound is a actual free interactive listening program that a lot of patients use. So it was, so Coca Corporation had Sound and Beyond, which you actually had to purchase. So a lot of people didn't purchase it and so they upgraded it, and now it's called Angel Sound, and tons of my adults use this for their auditory training. It's very popular. And so you can get it, as I said, free, and use it for all kinds of different, for music, for speech recognition, speech and quiet and noise, short-term memory, auditory cognition, all kinds of things. I found another one that I've actually not used, so I can't really talk that much about it, but it's called Auditory Concentration or Matching Game. It's auditory only. There's no text or pictures or anything, and it's timed and challenging. So that might be something you would want to give someone when they're doing a little bit better, not because you really don't want people to get frustrated. That's like really hard to have people be like, oh, I'm not doing well, or they think there's a problem. And we don't want people feeling like that they can't be successful with their device. That's the other reason why I don't usually test them in the booth until they've had their device for a while, because I used to do that and they would get really upset, sometimes even cry. And you don't want to do that. You want, no matter how much I counsel my patients, it's not going to sound good for a while, they're still really, really disappointed sometimes. I mean, I made a 19-year-old boy cry, not in front of me, but when he got out to the car, he cried in front of his parents and said he was reimplanted. And I told him over and over, it's going to sound terrible. It's going to sound terrible. And it still just was horrible for him. And I can't imagine what that feels like. So I'm not criticizing him, but he was so upset. Now he's doing great. But actually, this is kind of a funny story. It shows how good he was hearing. He's in college and he's in a fraternity. And his fraternity brothers, after he got the new implant, said, oh, you hear so much better. And I'm like, if guys notice that they hear better, then they really do hear better. So that was really good. That meant that it was working really well. But he was very disappointed in the beginning and really frustrated. And I've had patients who get kind of angry and upset, and I'm fine with that. And I totally, work with them. And the person I told you had meningitis, and his wife emailed me and said that he loves his streaming to both ears. He was one of those people who I could see on his face when he came in for programming in the very beginning was really disappointed. And he'd had normal hearing. So that's really hard. So there's also apps for iPad and iPhone. Of course, not everyone has an iPad and iPhone. People have Androids. And I think they're going to start trying to make some of these for Androids because it's really unfair. But there is an app for Angel Sound for the iPhone. There's Hear Coach, which is by Starkey. Again, I've not played with this, but and it's interesting. They say they challenge both cognitive and auditory skills, which of course is really good for elderly, for people who are older. That's terrible. I'm old. For seniors, because that one of the ways in which you can battle dementia is to use your brain, and so these. And of course, we've also heard the research that if you don't do something about your hearing, it can cause more mental decline. So the fact that these games also challenge cognitive levels is really exciting to me. I think that's really great. So of course, I've mentioned this before, but for children, they have to have therapy, and they really have to work hard. And Jody Haymond, she was actually a teacher of the deaf, but she was in charge of the cochlear implant program at Texas Children's. She's since retired. One of amazing woman. I really always loved talking to her. I learned so much from her. And one of the things that she told me, and I use this all the time now, is she would sit the parents down and say to them, this is going to be hard. You're going to make a lot of sacrifices. This is not going to be easy. But if you do the work, your kid will reach their full potential. And I really like that, because I think sometimes we want to make everything better. You want to say, oh, it's going to be fine, don't worry about it. But that can actually be detrimental. It is hard. And parents, I know that now have, children who are older or adults, and I ask them, they say, oh, it was a horrible time. But the kids now are doing great. So it is hard. And we have to remember that we're not there. We're not the ones who are dealing with this. And so it's really important that we are honest with parents about what it's going to be like. But we try to do as much as we can to help them in that journey, help each other. I always try to get parents to talk to each other and help each other along, which is really nice. So you want the children to use the family to use all this information at home. So if it's on computer, it's sometimes nice. And then if they're younger, you can just play games with them. But every child should be in a language-rich home and school or daycare where people are talking to them all the time. And even if it's way above their language level, just talk, narrate. I always tell people to narrate your child's life. Pretend they're blind and you have to tell them everything and use all the descriptors. My daughter at 2 years old, we were at a friend's house and she wandered around. She picked up this pillow and she goes, gingham. And everyone went, how does a 2-year-old know gingham? Well, because she had this really cute Baby Gap outfit that was gingham. So every time I dressed her and I went, look, gingham, gingham, gingham. I must have said gingham 20 times. So she knew what gingham was. It wasn't big. I mean, I'd like to say it's because she's smarter than everybody else, but she's not. It's just because I gave her that information. And I remember one time I had a hearing aid kid, who looked at me and said, that's not pink, that's magenta. And I went, okay. So we can't be afraid to tell parents to use language, use Paisley, use polka dot, use language that's above what you think they should do. Please don't do baby talk. Please don't use nicknames for things. Give the child a really rich experience, and they'll learn what they can. And then if it's too much for them, they'll just ignore it. But over time, they will learn all these words. And that's really important, because the one thing that cochlear implant kids will often have, I mean, this is one thing I've learned in the past several years, is we'd have these kids and they would be great listening spoken language kids. Their speech was beautiful. They heard it, they were doing great. And then in middle school, they started to show problems with vocabulary and other things. I had a parent who told me, she said something to her daughter, and daughter said, what does that mean? She was like, you don't know that word? Because they don't have as much experience with overhearing, and sometimes reading and language arts can be harder for them. So it's really important to give kids after they get out of therapy, to continue giving those children vocabulary. And the thing that I really emphasize, and I do this because of my experience with my own children, we were listening to, I think it was Anna Green Gables. And of course, they talked about her petticoat. My daughter said, what's a petticoat? I went, oh, well, of course you don't know what a petticoat is. No one says that word anymore. So I tell parents to read with their kids older books from other eras, Little House on the Prairie, those kinds of things, because it will have words that we don't necessarily use in our vernacular anymore. But it's really important for those kids to understand those words. So really a broad spectrum of language, and I told parents, just talk all day long. And when the kids go to bed, you can be really quiet, because it's going to be hard, but it makes such a difference. So.
Hey, Jolie, we have a question from
Sure.
Laura. Let's see. Laura wanted to know what your typical follow-up schedule is with implant patients, and when you typically do booth testing as a rule of thumb.
Okay, that's a good question. So I've kind of changed a little bit over the years on what I do, so I keep redoing it. I'm actually having a lot of patients who are getting reimplanted, either for failures are because they've got a really old device and they might fail soon, so they choose to implant on their own schedule. So most surgeons want us to wait about 3 weeks, sometimes 4 weeks. So I see the patient for their initial stimulation 3 to 4 weeks post-surgery. On that day, I do very little beyond setting them a basic map and some progressive maps because it's too much. They're overwhelmed. It's too much. I don't go into lots of descriptions. It used to be, I used to actually make my initial stim 2 days in a row. The first day I do mapping, the second day I would explain all the equipment. The good news is that there's so much more now that people can look up the things, they can see videos about things so that, because a lot of times if they're sitting with me, they're just not going to remember. And if they go home and sit in front of a video and I say, sit down once the kids are all asleep and go to a table and play with your device while you're watching the video and figure it out. So I do that. And then with adults, I usually see them a week later. And I often will see an adult every week for about the first month or so. A lot of it depends on what their progress is. So, and then after that, I'll go to a couple weeks or a month, then 3 months, every 3 months for a while, at least for the first year. Again, this does change a little bit with depending how someone's doing. I've had patients who did really, really well, so I could make those times longer. For children, I pretty much stay with the same timeline. So initial stim, I see them a week later, and that's when we really try to, I tell them to go look at your videos. If you have any questions, come back and ask those questions if you have, and then we'll go over things, and then we'll do our second map. And then I usually wait for 2 weeks after that to give them a chance and I give them progressive maps, by the way, so they do have things to really give them a chance to do therapy and to start just getting that used to wearing it and then I'll see them 2 weeks after that, and then I'll start doing it a month out. And again, a lot of it does depend on their progress, and that's why I keep in touch with their therapist to make sure that we're on the same page, and they might need to come more often, or if they're doing better, less often. But kids, I keep with more of a schedule. Adults, again, it depends on how well they're doing. If they're really going slow, I sometimes will wait till the 2 or 3 month range, because I don't want them to be disappointed. I don't want them to be upset. As I have had patients, I waited for 3 months and they still were struggling and they were really upset. So it's hard. Not that I still think by 3 months, I really would like to. Now, sometimes I will do just an audiogram just to make sure that they're not kind of wonky earlier. I probably will do that within a month or so. I'll do just an audiogram, no speech testing, because again, sometimes they're really struggling and I don't want to get them upset. And they're still getting used to it. So we're not at the final mapping. And so the information from that isn't as necessary for me as it is later on. So after that, I usually test them every 3 months for the first year, and then every 6 months, and then every year as we go along. Children, again, I might keep that 3 months for a longer period of time if they're still really developing that language. Because initially you can't do very much with kids after that. So I hope that answered your question.
I have a follow-up question just
Sure.
personally. Just having worked with Laura at Emory with mostly adults in CI, I know it was difficult for us to have quite as many follow-ups as it sounds like you're able to. Were you doing that in like the Auditory Verbal Center, or was that in a private practice? What kind of setting were you able to
So
do
I've
that?
always done that when I was at CHOA, when I was at speech school, and in the private practice.
Oh,
Now-
wow. Okay.
Now, sometimes, the insurance company won't let you see them that often. And we always take that in consideration. I don't ever want people to be charged too much. But I used to do a lot less. And I found that for adults, they might get frustrated between times because they really were, they were working and they were progressing. And then the map changes really were very, I'm not speaking right. Let me think it again. I was not talking that. So especially with my reimplantations, the week that when they get their initial stim, I say to them, you're going to hate this. You're going to wonder why you did this. you're not going to like me very much. This first week is horrible because I used to make people wait 2 weeks, but it was just too much. When they came in for their second mapping, it was a huge difference. So I find that for adults, I do want to do it a little bit sooner. For children, I sometimes will wait 2 weeks post initial stim with giving them the 4 progressive maps and having them kind of slowly go up. But again, I hate to say that I used to give people a paper saying, this is what you're going to do, and then I would end up changing it. But I do a general thing, and I say, this is a very general outline of how often you'll have to come, but you might be coming less or more than that, depending on what you're doing. And I work, as I said, I work with the therapist, and of course the adult can tell me how they're hearing. And then of course, we get that, we can decide what we're doing. So I hope that helps. So this is a list of some of my references. So hopefully you can look at some of those if you want. And then I'm done. So I don't know if there's any more questions. I'd be happy to answer any questions where everybody's questioned out.
I didn't see any other questions in the group chat. I think we kind of addressed them as we were going along.
Okay.
Thank you so much. That was perfect timing, Jolie.
I know I did. I got almost right under the thing. So
Yeah, very good.
It's hard to know when you're looking at size. I'm like, come along, am I going to talk? And of course, I add in all this stuff from my experience. And so I sometimes can talk a little over than what I expected, but I really appreciate being able to come. I love being able to talk to people. And in the future, if you have any questions, welcome to share my email with anybody. If anyone has any questions, I've been doing this for a long time. Not that I'm smarter than anybody, but I've been doing it for 35 years. So I have a little bit of experience. So if you ever have any questions, I'm happy to talk with you about it.
Thank you, Jolie. Have a great
Right.
night.
Thank you
Okay.
so much.
Bye, everybody.
Bye, everybody.